how do we screen and diagnose heart disease? Everybody knows about the ECG. ECG today we'll be studying after this in detail. So how many say that ECG is the diagnostic test for heart disease? Do you think it is 100% diagnostic? How many say it is 100% diagnostic? If your ECG comes normal, does that mean a person doesn't have a heart disease? So ECG can help you in finding out many heart diseases, because ECG will reflect the electrical activity of the heart. So if there is any change in the electrical activity of the heart, it will be shown in the ECG. But if the ECG is normal, doesn't mean that there is no underlying heart disease. So what is the next test that we do is stress test. Stress test, make a person walk on the treadmill and then record the ECG, record the blood pressure, and then you find out whether this patient is having any ECG changes or any changes in the heart rate or in the blood pressure during the exercise. So then we come to know whether the patient is having any deficiency in the blood flow to the heart. So if we find out on the stress test that patient is having some sort of less blood supply to the heart, then what is the next? How do we diagnose exactly that where the problem lies? We do an angiogram. So in an angiogram, it shows us specifically where the blockage is and what should be done, whether it is severe enough for some intervention or whether it can be managed medically. So everybody is clear about this. And we have echo also. Echocardiography also help in determining the pumping function, in the flow of blood, whether the valves are leaking or not. Today we move on to the ECG. So anybody who knows how to read an ECG, raise your hand. Anybody knows how to read an ECG?
Firstly, we will, if we have an ECG, so firstly, we will monitor the frequency of an ECG.
Today I will tell you just the basic thing you should know. Okay. That's nice. So ECG is one investigation like everybody should know, because your neighbor or your friend, somebody can show you ECG. Is it okay? Nowadays they send on the WhatsApp. They send the ECG and then they ask, what is the diagnosis? ना तो टेस्ट लेते लोग आपका, हमारा तो लेते हैं, आपका पता नहीं. So here you can see, first before we discuss about the ECG, can anybody tell me what is an ECG? So it is basically a record of the electrical activity of the heart. So our heart has an electrical activity. So how the electrical activity goes on? Anybody knows that? Or should I tell? SA node and AB node. So what is the pacemaker of the heart? SA node. Very good. Everybody clap for yourself. I really enjoy coming to such classes. Everybody knows everything and I don't have to tell much. But still I will tell you a little bit more. That our heart has a quality that it can spontaneously generate electrical activity. So all the muscle of the heart, it generates electrical activity, and the rate at which the electrical activity is generated, it is different in different parts of the heart. So this is the right atrium, this is the right ventricle, this is the left ventricle, this is the left atrium. So the atrium, they generate activity at a faster rate compared to the ventricles. And the fastest activity is generated by the SA node, which is at the junction of the superior vena cava and the right atrium. And SA node generates maximum electrical activity at a faster rate. So that's why it takes over, because all the muscle, it has to follow that rate. See, if suppose I am doing some activity at the fastest rate, then all the people sitting in this class have to follow the same rate. Suppose I am clapping and I tell everybody to clap. First I tell physiotherapist, you clap at a particular rate. So you clap. Physiotherapists, please clap. Now I tell dietitians, please clap. And now I tell the forensic people, you clap. Now I am telling the nurses to clap, and you clap at the fastest rate. So now all of them clap, and you clap in synchronize with them. Clap at the same rate at which the nurses are clapping. Nurses clap. Stop. So now I understand the person who is clapping at the fastest rate, rest of the muscles, they are following the same rate. So this is known as the pacemaker. So here, who was the pacemaker? Nurses, because they have organized this workshop. So maybe next time physiotherapists will be the pacemaker, and after that dietitians should not be left behind. So you also have to organize some event and call everybody. Okay. So this SA node is the pacemaker, and this AV node, this is between the atria and the ventricles. So this impulse goes from the SA node to the AV node, and at the same time this impulse goes to the left atrium also. And once it crosses the AV node, it goes into the bundle of His, and then it divides into the right and left bundle branch, and then they divide into the Purkinje fibers. So everybody knows this, I am supposed. Okay, so now we come to the actual ECG. So ECG, first wave is the P wave. So this P wave is because of atrial depolarization. So this is the positive wave, and P wave is usually followed by the QRS. So this is the Q, this is the R, and this is the S. This is the QRS, and this is followed by the T wave. So QRS is because of ventricular depolarization, and after that this is the repolarization, and this is the T wave. So the entire ECG replicates this pattern: P wave, QRS, T wave. Okay. So now one is a simple ECG. Simple ECG, what you do, you put in the electrodes and you make the patient lie down, and then you record the electrical activity. Next is the stress test, when you put the electrodes and make the patient walk. And then another thing is the ambulatory ECG, what you call the holter. We put the machine and send the patient home, and then tell the patient to come after 28 hours, 48 hours. So it records all the electrical activity of the heart, and then it shows us whether any problem is going on or not. Because when the patient comes to us, at that time there may not be any change in the ECG, but maybe after an hour, or maybe after 12 hours, maybe after 24 hours, patient may be having some change. But when he comes to the hospital, by that time the change may be settled, so we will not be able to find out what is going on. So for that we can use the holter. And nowadays, you think we have anything else available? Like, can we see the ECG on a mobile? So nowadays we have apps available and a small device which we can use. Just you have to put your thumb on the device and touch it with your skin near your ankle, and we can record your ECG on the phone, and then we can send it to the doctor or the person who will diagnose what is the problem. So whenever a person has a problem, holter also you can keep at home for maybe a week, but you can't keep it permanently. But this device you can keep permanently, and whenever you feel there is a problem, you just record your ECG and send it. Automatically you can just message it to the doctor. So day by day we are having development. We put the electrodes on the right arm, right leg, and then we connect it to the machine and we put the chest leads. Chest leads, they are put on the, you've seen those ECG electrodes. Similarly, when we want to record the ECG, we put the electrodes on the chest. So first one, that is V1, that is put on the right side on the fourth intercostal space. Then we put on the left side in the fourth intercostal space, that is V2. And for V3, it is in between V4 and V2. So V4 is in the fifth intercostal space in the mid-clavicular line, and V3 is in between V4 and V2, and V5 is fifth intercostal space on the anterior axillary line, and V6 is on the mid-axillary line. Okay, so even if you don't understand now, when we come for the demo, at that time you can ask and then we'll tell you. This slide shows where each electrode is put. Then we have to see that which lead reflects which area. So here I can show you a diagram. In this diagram, the leads AVL, lead 1, this is the left lateral side of the heart, this is the left ventricle. So these leads, they record the lateral side activity of the heart, and here lead 2, lead AVF and lead 3, this records the inferior surface of the heart, and then this AVR records the right side of the heart. This is the right atrium, this is the right ventricle. So by remembering this diagram, you can know that which lead records activity of which side of the heart. So this is a simple ECG, and here you can see this is lead 1 between the left and the right atrium, lead 2, lead 3. This is the rhythm strip. So lead 2 is taken as the rhythm strip. Whenever you have to see the rhythm of the patient, then you need a long recording of the strip of ECG. And then here you can see this is the chest leads V1, V2, V3, V4, V5, V6. So I will subsequently tell you what changes can be seen and how we can see these changes. So before we start with the ECG, first we have to calibrate the ECG. So do you know how to calibrate? We have to record the patient's name, age, why patient came for ECG, all the things you have to record, the date on which you have done the ECG, and then we calibrate, then we fix the speed of the ECG, and we then see the rhythm, and we see the axis, and then we see the specific things, whether we want to see for any changes in because of myocardial infarction, or we want to see changes because of some electrolyte imbalance. So, and we have to see for heart blocks. So that we'll discuss one by one. First of all, how to calibrate. The height of one square is 5 millimeter, and normally 1 millivolt represents 10 millimeter. So there is a method to calibrate. So when we press that, so for 1 millivolt it should go up by 10 millimeter. And then when we run the ECG, the speed should be 25 millimeter per second. So each big square, it has 5 small squares. So first we calibrate that speed should be 25 millimeter per second, and 1 millivolt show a deflection of 10 millimeter. So once we have done this, then we record the ECG, and then here is the recording, like this is the P wave, this is the Q, this is the R, this is the S, and this is the T wave. And then we have important segments like the PR interval and then the ST segment. So PR interval is normally how much? it is 0.12 to 0.2 seconds. And then we have the QRS. QRS is usually less than 0.12. So whenever there is a change in this, then it can reflect some underlying problem. How do you calculate rate? Anybody knows how to calculate the rate in the ECG? Do you know? Or should I tell? So here you can see, first we have to calculate the number of large squares between the R waves. And when we calculate the number of R waves, then we have to divide 300 by the number of large squares between the R waves. Suppose the number of large squares between the R waves are 4 large squares, then we divide by 4, so it becomes 75 beats per minute.